associate professor now, I think, at Tsinghua. He was trained as an operational research, so OR person. And at that time, we don't know how to analyze, do NLP, natural language processing, how to deal with free text data. And the whole team was waiting for the computer scientists to finish their algorithm and to pull the data. We were waiting, literally waiting for 6 months. And also, even during that period, they wouldn't explain to us how to use their software. They were not very nice to us. So Shen, as an engineer, just said, I'm going to do it myself. So he spent about a couple months, almost a year, to write his own software. Ever since, we do our own NLP, and that was sort of changed my mindset. So that really is literally my pain. I don't have data, I have to beg for data, and not all of my colleagues are willing to facilitate my needs. So then 15 years later, we go from the very beginning of EHR data. I can download any kind of raw data to all the way end to the final project. So I'll give you some of the examples that in terms of the study. But before that, I do really want to thank Tian and Hongyu and the organizers here for the kind invitation. And I'm really excited, as you can tell, my loud voice sometimes, about the mission of this workshop. So I'm going to do a big sort of overview of what are the challenges, opportunities using EHR for translational research. And I'm going to touch upon 3 aspects of like EHR, to me, like what kind of research that we are excited about in addition to this translation end. So EHR data, even though it's super valuable, the resolution is low, it's very noisy. So we're trying to develop algorithm to improve the resolution, make the data quality better. It's also like has this major issue, transportability. An algorithm developed in one system is not transportable to another, not really only because of distributional shift. Like we did a lot of transfer learning methods for distributional shift, but this is different. We have coding system that's different. You have language that's different. So how can we achieve that automatically? So then I become excited about it because the infrastructure side actually becomes very interesting research. It becomes an algorithm developed, not like I have some students sitting there to do hard coding. I will also talk a little bit about federated collaborative learning, because for most of the EHR research, usually you are not very certain if you just have one study. So usually you do multiple studies, and how can you actually work together to create a network? So I work a lot with different consortiums to build up this called a federated network. We actually have a granted due this Friday. I have to work on that on the flight back, because we are helping the NIH to establish this like aim-ahead consortium to help sort of more resource-poor universities to build up their EHR for research, become like the different nodes of the network. And then we also have to provide algorithms. Like once you build it up, what do you do? So I actually had my slide, about why EHR research is so important, and that's my nightmare. When I remember chairing a session for the NIH about like AI for cancer research, and I asked like real-world evidence, and the answer was so good that it scares me. But fortunately, this one is not so good. So the one on the left is from BART, and the one on the right on GPT. I think the ChatGPT, I use more ChatGPT, so the answers are better. But anyway, if you can just look at the common theme, there are a few things that make EHR data very attractive. One, like from, for example, FDA perspective, it's really real-world data. It represents, right, people who are sick in the health system. They really want to know, in the so-called real-world effect, like evidence, right? It's longitudinal data, so it's temporal data, both from the patient's like disease trajectory and also temporal in terms of like, people who have the condition in early 2000 versus like 2020, they are actually really different. So there are different kind of temporality. But this kind of temporal trend allows us to evaluate many things, and including developing clinical decision support. Of course, you can also do real-world evidence. But I will also mention how you can actually integrate EHR data with many other kinds of data in different ways to address much more sort of exciting kind of question like drug repurposing. Can you predict a chemical structure? What is the potential effect of the drug? What is the potential side effect? That to us, I have to admit, I know zero about biology. I skipped biology even in high school, so I had none. But I really appreciate what Annie said. Like, I have a student who is interested, so I'm willing to be part. That I'm part of the team. I cannot be the main driver, but I'm willing to learn. So we actually worked on like drug repurposing. Can you actually infer the drug effect linking with genetics, protein, and different levels of information? And that data integration is much messier, but it's also exciting. How do we do that? So for those who are not familiar with the EHR data, I want to emphasize one key thing about EHR data is that they have two main types of data. One is so-called structured. So if you write a SQL code and pull the data, there's no error unless you make a programming error. So they are structured, like they're tables, pull the data out. There's also free text. That's the most valuable data in the EHR. So not only you see what codes are given, what lab results, prescription, there are justifications. Why do I do that? What symptoms do I see? And you also see, like when you see a side effect, that the doctor actually document whether the side effect is due to the treatment. So you are much more certain that when you see a side, and some kind of reaction, it's actually a reaction to the drug, not a natural consequence of the disease itself. So for the unstructured data, of course, given the rise of large language model, people also have huge interest in like a retraining Llama 2. Can you throw that in and make a Llama 2 like do QA for, like mimic what the doctors do? So every one of us are interested. Of course, we're interested as well working with the VA. But to me, like I also don't want to be the slave of the language model trying to figure out how to fine-tune that. We also use language model to generate certain like silver standard label, noisy label for me to train the algorithm that I'm interested in. So that's just, but in general, we treat like free text data more as sort of a data element. So you can run simpler NLPs to extract certain kind of data. Is there a mention of schizophrenia in the notes? Is a mention of the drug? Sometimes when the drug is so new, you only see in the notes, they are not actually coded. And also, of course, signs and symptoms, you only see in the drug, in the notes. And also, like even cancer stage, histology, many cancer characteristics, they're only in the notes. So EHR data itself, like just as in terms of all the codes, medications, they're already very rich, and also they're longitudinal. So they encode any condition that the patient has. All medication prescription, procedure, lab measurements. As I mentioned, you also can run NLP, cover all kinds of signs and symptoms, much more detailed information. And then we do have other data types, including imaging. So that's one thing that's very valuable. We not only have image, if every image has a report. So like we talked about the pain of not having segmentation. I'm usually driven by my pain. I don't have segmentation. I've been setting up this contract. For 6 months, I haven't finished just to do segmentation because I cannot pull the data out. So I have limited people who can do this for us. But at the same time, my colleague, Junwei Liu, he's an expert in imaging. So trying to see, can I actually link the report? I can extract information with the report, co-training with the two, and basically bypass the segmentation. You have pre-trained model, right? You can transfer learning to do a good job in the segmentation, but just not so sure if it's doing a good job, so I want to augment with the report information. So that's sort of the benefit. And we do link EHR with disease registry. So there's certain outcomes that I work on rheumatoid arthritis. The major outcome is called the disease activity. So disease activity score usually is not routinely collected as part of clinical care. But registry, that's like clinical trial endpoints, basically are not routinely collected. But they have registry, so we're linking registry with the EHR. At the VA, because they're so huge, they also run a lot of clinical trials. So they also link clinical trial data with EHR. So then I can actually do comparative effectiveness so that we actually have an ongoing project that link the two to, basically I feel a little bit more confident to do comparative effectiveness because I have randomized trial linked. We do also have biobank. The VA has, for example, the million variant project. They have a genotype of almost, they recruited the millionth veteran last November. They actually had a celebration. But they already genotype about 750,000 patients, so you can link. And then you can, of course, link. We are publishing, right now it's in revision for Science, basically the first paper looking at the whole GWAS, not sequencing yet. The whole GWAS of PWAS. Basically, for every SNP, I want to know against every disease phenotype. So give us a lot more. And also, VA has a lot of diversity in terms of patient population, so it's very helpful. With EHR data, like how do we actually link to the ultimate goal of helping patient, right? So obvious thing is to do like dynamic risk prediction. You know, you can rewind the data at any point to predict, pretend that this is the clinical visit. Like right now, we're working on a project of predicting suicide ideation. So we team, the key PIs are actually psychologists and psychiatrists looking at suicide ideation. And we developed an algorithm to predict the risk of suicide ideation using longitudinal EHR data under different clinical settings. You can be at primary care. The patient has some issues, maybe like depression. They could be at much higher risk compared to the general population. You could also have patients who already have mental disorders, and those are patients might already are in the ED. They're already in the ED because of some condition. So they are already base risk is a lot higher. And then you have inpatient, they're already hospitalized. So for each of the clinical setting, we actually have studies that like the next step. What is the next step that we can help you? Because health system cannot help them that much. I'm very excited about this project is because they are actually connecting with a nonprofit organization that help them to give the patient support in a more gentle way, not like relying like hospital to keep them in the hospital, so that's not feasible. So we developed an algorithm. Right now, we're planning a randomized clinical trial in the spring. So we're trying to figure out like how does it make it work. So this is a setting that you actually have to find people to develop the app. So where the team is looking for a group that develop app and go inside the health system. So we did find that general outpatient, the AUC is very high, but the base risk is very low. But if you look at the relative risk, they are more than 10 times. So you will at least flag them, but you're not going to send them to the hospital. So for those patients, it's much more like maybe they need family support, right? We need to think of things that are more sustainable. But if you look at, psych like emergency department, so you can see AUC is already lower because they are more similar, right? So how do you help them? So these are the patients actually we're trying to see what can we do for them to run trials. So as I mentioned, we also link with genomic data. And one kind of study that we did is to look for particular variants that there is like functional variants. So for example, this is a PWAS study that I did with my colleague, Catherine Liao. She's a rheumatologist. I've worked with her for like 15 years. We look at this particular variant is IL6R. And this variant corresponds to the drug of tocilizumab. Basically, the tocilizumab was developed to target this gene to inhibit the production of CRP, the inflammation marker. So CRP inflammation is super important for rheumatoid arthritis. So they use for tocilizumab, but tocilizumab is used actually for many autoimmune diseases, for example. So this one, we are actually curious about the potential alternative indications of the drug. So we look at the genetic variant and run a so-called PWAS. Basically, look at every single disease condition. We're searching for and see what other effect does it have. So we did pick up, at the time of our publication, we did find that there are other studies that identify tocilizumab has a protective effect of cardiovascular conditions. So here we see a bunch of different cardiovascular conditions, including aneurysm. We did also find the drug side effect. It's like a skin irritation. And you can find it in the original trial. That's one of the indications, like a side effect of the drug. As I mentioned, you can link EHR data with many other data types. But because I have a really painful situation that I can never share EHR data outside of the system, so what we have been doing is that we derive a lot of summary level data. So we hear many people talk about, embeddings, et cetera, right? We actually created embeddings using the EHR data. So each of the EHR concept is represented by a finite dimensional embedding vector. That I can transport out. Now I have that, sorry, how do I go back? So now I have that, I can link with all kinds of data. So we treat this like a knowledge graph, a link prediction problem. So I can bring like foreign entities into this. So for example, we looked at chemical structure of a drug. They may or may not actually already have a drug developed on the market. You imagine that drug companies, right? You are in initial stage. You still only have the chemical structure, and then you have, some protein functions, et cetera. So we linked our EHR embeddings with the FDA. Also have a list of drugs, chemical structures, et cetera, and document what are the indications, what are the side effects. So once you link the two kind of data sources, we actually benefit from the relationship between different diseases and drug and the phenotype that we observed in the EHR to make this a much more powerful analysis. So we were able to predict for example, the indication of the chemical structure. You can also segment your training data into by time, right? You can look at the drugs developed up to 2020. The drugs appear after 2020 should not be in your training data. So you can look across year to see does it do a good job. Recently, my postdoc, he's also interested in studying the effect of missense variant. So some of you probably saw a paper published by DeepMind earlier last year, alpha missense. So they are trying to predict whether a missense variant is pathogenic. So there are actually many papers on that. Alpha missense did very well because it was actually unsupervised training. And but so far in the literature, they only know whether a missense variant is pathogenic, does not know what does it do. What disease does it cause? So we are part of this undiagnosed disease network. Harvard Medical School is sort of the data coordinating center. So we work with many of the institutions. They have actual patients who have undiagnosed disease. And what we did in this study, basically, we were actually trying to predict what is the likely plausible condition. We rank order the top condition that can this particular variant predict. So we validate using the UDN, which is not in our training. Right now, we are actually setting up the final analysis, I hope, that we identified one of those patients that we predicted, and the UDN has not yet diagnosed them. They prioritized the variant, so that means that they have some idea. But prioritize is not perfect, and they don't just prioritize one, right? So we were able to predict, and we're trying to go back to the clinician and say, do you think that's a plausible condition? And we also validated that there are certain conditions, even though they are causal variants, but you can actually diagnose the disease relatively easily using lab tests. They are almost perfect. So in other words, I have other mechanisms to diagnose the disease, and we can use that as a gold standard, right? I can look back. Then we can also tell the UDN people, these should be the causal variant. So they already diagnosed it, but they don't know for sure which one. So we also use that to diagnose. But I have to admit, again, my lack of biology training, this is as much I can talk about. Don't ask me any more questions about the biology side. But I find it fascinating. And for that, I'm very happy to be the team member. To just listen, to learn from the clinicians. We have a clinical, he's a geneticist and cardiologist. So we are super happy team together. So this is one of the studies I'm most proud of. This is a study that we did, I would say by now, it's almost 3 years ago. FDA reached out to us. I teamed up with this person, Florence. She's a clinician. She's also the co-director of the Harvard-MIT Center for Regulatory Science. So FDA at that time had a congressional hearing coming up about a particular device, so EVAR. It's for endovascular aneurysm repair. So the EVAR there's this company that Effects. They have different iterations. The first 2 iterations already pulled off the market because of the side effect. So the Effects 2 was already the 3rd generation. They're supposed to already fix the problem. But there's some signal saying that they might still have a higher side effect compared to the traditional devices in the market. But FDA is a little worried. Don't know for sure. So they reached out to us. They wanted us to do this study with them. Basically, they contracted us to do the study to understand whether or not this particular device really has a higher risk of this particular endpoint called a type 3 endoleak. And basically, they start bleeding at the whatever site. And the type 3 endoleak is not coded at all. It's only in the notes. And this is also challenging because there's a lot of negation. Because FDA already started worrying about it, so all the clinicians will document, no, the patient does not have type 3 endoleak. So basically, you really need NOP to do well to capture it. But this is a study we went really from the very beginning. They just have a question. And then we went from building the database to all the way to the end to generate a report for the FDA right before their congressional hearing. But that was really scary because that's a part of if I mess up, I'll be so scared. I'll probably lose my tenure in that case. But this is a very interesting study. If you look at we only have the endpoint up to year 5 because that's the last follow-up. So basically, the new device, type 3, the FX2 was only on the market up to that time. But if you look at so this is we did, double robust causal modeling, et cetera. So this is, if you look at the event rate, and this is the side effect, the difference of the event rate. The difference. So what you can see here, here. So if you can see from here is that the orange one is the one that's the one on the right is mortality. The one on the left is the type 3 endoleak. The orange one is the one that you should be looking for. The one totally flat is the non-effects based on your reference. They start to seem to suggest over time they're going up. So because of that, FDA actually at that time basically gave them a warning. They didn't pull off the market, but they say they're potentially has. They don't know for sure, so they suggest to basically don't use it unless you have to. But they are not pulling. So this is one of the studies I really want to go back. Now I have 7 years of follow-up. I wanted to see, do you actually see more uptick? So of course, given all these potential, right, there's a lot of hype about how you can leverage EHR data, but there's a lot of problems in the EHR. First of all, it's very noisy. So codes, they are optimized for billing. So that's why people love Epic, because they make more money for the hospital, but it's a terrible EHR system to use for research. But they still use it. There's a huge miscoding. For example, at the Brigham, among patients who have at least 3 ICD code for rheumatoid arthritis diagnostic code, only 58% of them actually have RA. So that's terrible in terms of misclassification. And also in the old days, I went to a study with clinicians, we talk about what you want, and that's a very bad practice because even if they give you a list of features, one, they may be subjective, right? If you ask another clinician, they might want another set of features. And second, you have to then manually map what they say into a variable that you want, that's too manual a process. So that's sort of one of the pains. That's why we develop knowledge graph. We go from the raw EHR data instead of going from the clinician. I show them, here's the feature. Tell me which one if there's more you want, I can add. But usually it's comprehensive enough. So we almost can bypass clinician for the manual checking of the feature. But as I mentioned, there's transportability issue. There's also health system bias. Like VA, for example, predominantly male, which will not allow us to study much of the information about female. There's also, other biases like Mass Brigham, MGB is like a tertiary hospital, so they tend to treat a much sicker patient, et cetera. So that will give us some potential susceptibility to unreliable or generalizability. So I'm going to touch upon all 3 points, like how can we actually improve data quality, improve the transportability and generalizability from like algorithm or methodology perspective. So to increase the resolution, we do a lot of so-called EHR phenotyping. So basically, it's like some kind of algorithm that instead of using a code to define yes, no, or at a given moment, yes, no, we use an algorithm to predict, become a classification problem. This is a more or less like a standard, if it's a classification, right? We've done classification for decades. So I'm just like briefly list of what things that people are doing. There's a rule-based, of course, that's not very generalizable sometimes. There's supervised, semi-supervised. So those all require human curation of the label that require them to do chart review. We still do that to a certain degree because I need to validate. But otherwise, it's labor intensive, so it's not scalable. You cannot do like 100 or 1,000 phenotype. People have also done a lot of so-called self-supervised or weakly supervised. So you can think of like ICD code. It's imperfect, but it's good enough. It's a noisy version. So you have to think about like, what assumption are we making when you say noisy label? What kind of misclassification or error that's in it that justifies that I can train a model using that as an imperfect outcome? So there's a lot of interesting algorithms or both statistical and machine learning. People have developed algorithms, and also we do use a lot of clinical notes. So obviously attaching the large language model is very useful for information retrieval. I want to focus more on the second part, and my biggest pain point is the data itself, quality. So, and also transportability. So the transportability, as I mentioned, if it's just a distributional shift, there's many tools. I'm not even going to do any review. Many of you here develop awesome methods. I'm talking about a different issue. There's a heterogeneity in coding. So far, these consortiums that I'm talking about, we actually still do it manually because they don't have the capacity to set up the system. So if you want to study CRP, for example, you actually have to go to each of the hospital to figure out what is the code. They're all different. And then basically, if you don't know that, you can't even do the study. You need to figure out what is the base code that you need to use to represent this particular feature. So I want to talk about the kind of work that I've been doing in the last at least 5-10 years, like thinking from the sort of methodology or algorithm perspective. So when I first went to the VA, we were already working on it. And I told the VA, hey, I have this fancy algorithm. I'm going to automatically assign your local lab. So their lab codes are all like not organized, majority not organized. So basically, every hospital, VA has 1,200 like clinics. So every clinic can be sending their lab test to a particular laboratory to process it. They come back as a local code. So they have 400,000 lab code. At Mass General, about 2,000 after they map to common ontology. At BI, we have a very experienced informatics person. They only have 200. So in other words, the majority of the labs that are done in the US, you should be in the magnitude of a few hundred to like 2,000, not 400,000, right? How can we help VA, this kind of system, to really automate? Can you have like a smarter Google search? A search, like you come to the website, you search in CRP, At least if they pop up, you can say, these are the things I want. So that's what our goal is. To basically, I cannot perfectly map them, but I can do a smarter search. How do we do that? So that is done mainly through so-called representation learning. Like as Xiao mentioned, most of these are like some kind of dimension reduction. They can be nonlinear dimension reduction. It doesn't have to be linear. But as a statistical problem, I find it really fascinating. So I did one of the papers with Xu Shi. She's now assistant professor at Michigan. Oh yeah, that's the only paper I ever got some kind of award. I still have it $333. Xu did a wonderful job, but she just kind enough shared the award. Peter helped us to get the award. I'm going to donate my money to take the kids out to like a bar. So the basic question is, I have two sets of codes across the two health system. Some of them have dictionary that's mapped. Can I turn it into a statistical problem to say you are predicting, basically for future codes that are not mapped, tell me which one I should go. So how do we turn into the data, right? But if you have like a representation, so basically you embed, you create this semantic embedding for each of the code, you have a vector that becomes the data for the code, then it becomes a regression or classification problem, right? The reason that paper was fascinating to me was that our dictionary is imperfect. Because the manual mapping, none of them is perfect. So there's distortion. Basically, you have like misaligned data, but we assume a small percentage of misalignment. Like, can you create a method to justify why it's supposed to work? So basically, if you write into a statistical framework, you have, y1 to yn is from one system that, again, each of the is a vector of embeddings, and x1 to xn. What you are trying to learn is this, whoops, what did I do? Whoops, I don't know why. But so basically, the W here is so-called the translation matrix, and the pi here is the mapping matrix. You are trying to learn both of them. And one thing I find really interesting in this kind of like us thinking about a statistician is that most of the existing work is doing this kind of one-to-one mapping, but it's never one-to-one. For example, we do like ICD-9 to ICD-10 mapping. ICD-10 is much finer. So the number of codes are not like, they're naturally not one-to-one. And sometimes you need a bunch of codes to represent a bunch of codes over there. So that's sort of one of the main things that they did. But basically from a statistical problem, it's a corrupted regression problem. Like you have some corruption in the system. You can also think of this as a link prediction problem, as a knowledge graph. So the embedding, like a lot of the machine learning literature, they call this like a knowledge graph embedding. So basically you see like a graph, but the back end of the data is embedding. So if you think of that, this just like you have a bunch of nodes, and a bunch of nodes, you become like graph alignment, right? Or link prediction, like which of the two nodes are like synonyms. That's one kind of link that I want to predict. And then once I can detect that, I'm going to just connect all of them. So that's sort of the interesting part. And here, by the way, I just learned from Haoda yesterday, which website to actually use to create AI-generated graph. I decided to use Firefly. I uploaded, I just wanted a cartoon to be fun. So basically, just imagine that in this case, I have 3 health systems. UPMC is a University of Pittsburgh Medical Center. I have a long-term collaborator, so he shipped his data to our server. I have data from the VA. I have data from Mass General Brigham. So I have 3 health systems. They have different nodes, and I'm trying to link them. But also, my end goal is not to just map them. If I can join to represent them, their representation, talk to each other, then it's actually much easier later to do transfer learning, because they're all embedded in the same space. So we did, for this particular project, usually our team work, like we solve the problem first. Like I don't actually view myself as a statistician. I just want to solve the problem. So for this project, we actually used a lot of graphical neural network. And it does do better. It does have a lot more flexibility. We also use a lot of GPT to generate like silver standard labels. If I have 2 codes, I can ask, can you tell me what's the long description? Because sometimes it's an acronym. Like your own algorithm doesn't do well to learn like WBC, white blood cell count. But if you ask GPT, it will tell you it's supposed to be white blood cell count. So we first ask it to expand it, and then we have initial algorithm to say these are the top 5, and we ask GPT which one is more accurate. So we did find, by the way, GPT-4 is a lot more accurate, but it costs me more money, so I have to ask them to watch how much money you're spending. But they count by token. Yeah. So, but it was very helpful because it generated many links for us to train the GNN. And in the end, basically, we also, one thing I want to say that these codes, like initially when we trained the algorithm in the previous round, we only look at how the codes are used in the EHR. So I'm heavily relying on sort of the clinical representation of the code. But there's an orthogonal information is the description of the code, the words. That like we never used. So then we use a pre-trained language model to embed the words. And what we found is that they're very complementary to each other. They're not the same in terms of their strengths and benefits. So we actually do use both sources of information to understand what does it do. And in the end, basically the final product is that I'm able to embed all codes across all health systems. And once we set it up, we are now talking to our potential customers. Hey, this is, I have 3 nodes. You want to be one of the node. Then they'll be willing to create the summary level data that we need. And then they will be part of the node. And then we will refresh our algorithm. But once you have the embedding, you can really do a lot with the data. So here, I just want to show you one sort of the case study. We just look at a lab. VA has a lot of lab code, and we did the mapping to the low code is a common ontology. So here, our algorithm is the one on the bottom, and I just want to show you that is purely unsupervised. We did not use any human annotation, although we did use GPT, so I wouldn't say it would be like weakly supervised, but we can do as well as a supervised, so we can bypass any of the human annotation. The last point I want to make is how can we unlock the data value through federated collaborative learning? So we treat each of the nodes in the network as really, they contribute unique information. But there's, of course, heterogeneity, right? Not only the patient population, their outcome model, for example, may not be the same as my outcome model. And particularly, how treatment is used in the cross system are very different because they have insurance. Like they have different insurance types. Like VA doesn't have insurance problem. So they have a particular way of requiring how medications are given. And of course, the privacy constraint. I cannot share individual level data. So I just want to point out at a high level, what kind of things are interesting. So again, we are very good at if you just think about all the current federated learning algorithms that we have developed in the statistical community, most of them basically think about there's some kind of shared structure. You need to have something shared, right? So you can learn from each other. But you do allow for certain kind of heterogeneity. You can say, part of the coefficients are similar, part of them are not. There's also a lot of emphasis in improved efficiency, how much communication. Oh, that's very important. Apparently, Michael Jordan gave another very fascinating talk. He said, it's really, at the end of the day, it's economics. What's their motivation, right? Again, I learned in a hard way. I have to have my research associates started talking about life with their research associate. Hey, what music do you want? They have to be friends in order to run it for you. It's painful for them to do this over time, right? So in other words, communication is important because there's human value in it. There's also a lot of work, for example, Hongzhe, and I know many of you guys also work on differential privacy, right? But to me, if I have to pay such a high price for the distortion of the end product, basically there's a sacrifice, right? You add noise to it. The signal is already so weak. You add noise, I can't do anything. So to me, I'm not interested in that. But I'm interested because I'm willing to trust my server on HMS. So they are willing to share summary level data with me on HMS. So then it's okay. I just need summary level data. I don't need differential privacy. So that's just my personal sort of desire, just because our signals are weak. We have a lot of interest in the improved robustness in terms of, just imagine that you want to train a model that's useful for a future target population. May not be one of them, right? So there has been a lot of work in recent years and like so-called distributional robust optimization. Basically, they wanted to make sure that in the future target population, if it's a mixture of your current source population, it cannot do very poorly. So they have this kind of minimax or max-min kind of concept. We have also been doing some work on consensus learning. So sometimes, this is an interesting story. We have this consortium for COVID. We started in March of 2020. We work with many institutions from like 8 countries, many different sites. There's one site from Italy. Oh, their data is so bad. So in the end, you look at it, it's just so off. You always kick out. Penn is another example. I'm not going to say which one. A chop, yes. I was going to not say chop, but it's really chop. Every time we look at it, it's so off that I have to take it out. But it's manual. So we're also interested, can you actually automatically kick it out? So there's this sort of consensus learning. Basically, it's almost like post-selection inference, right? You have to use the data to determine, and what if it's sort of on the boundary? Then the inference become a non-regular, because you have to pay the price. So how can you do a proper inference to account for this kind of inference? So I do work, for example, with Zijian Guo a lot on this, because he's an expert in the theory part. We have this strong motivation to say this is what we really need to achieve. And last thing I want to touch upon is the dissemination. So one, I do have a huge desire to just train the algorithm using summary level data, because I can convince my friends. I actually also often take them to lunch, have like a social time to gently convince them, but they'll be willing to share summary level data. So if your algorithm is really trainable on, this is our web API, this is Shiny. So they upload it, they click a button, they train the algorithm. Then they're willing to do it. Actually, many clinicians are very excited about it because they also think about their friends. They can group them into our network. So we develop a lot of the APIs that actually allow people to train this algorithm. And as I mentioned yesterday also to Susan, we actually work with a nonprofit organization. They do the last mile for us. They even create a automated video with instruction. I just do need to give them the text. And they create a video. It was awesome. So for each of the app that we develop for VA actually loves it. So VA now gives a contract to the nonprofit. And they go from the beginning to end, including this kind of video with instruction. So that's the last mile I think we really need. It's very important, but it's not necessary research, right? So I outsource for them to do that for us. So just to wrap up, I think there's a lot of potential in using EHR data to do sort of reliable and explainable AI. I still like the model and to understand the model, but I don't usually badmouth just to say, oh, you have a black box. If they have a black box that's much better than mine, I have no say. But if we have similar performance, then explainable is very good. I'm very passionate about improving the EHR quality, and also I feel like the data access issue we talked about, I feel like we should do something. I almost feel like it's a democratizing AI research, right? Because otherwise, they don't. For other people who want to enter, it's just too long of a process. And also, there are bit different methods to improve, for example, overcome the bias in the health system, and to mitigate this so-called hallucination. That's where sort of explainable is helpful. So we also create a lot of knowledge graph. So instead of using random features, we actually tell you what features might be useful. So sort of using the knowledge graph to guide it. But the last point that I want to talk about, data science, much of it, I believe that it's science of the data itself. Like you need to understand the data both from how it's generated so that you can talk to the informatics database people to how to interpret. You can talk to the clinical side. But I think one thing I really wish that our students have more is curiosity. You don't have to know it, but you should be curious enough to listen to other people. And eventually, when you listen enough, you can be more on the equal footing to talk to them. So that'll be it. Thank you.
I think when we take questions, we can get the next speaker. I think Xinzhou, your next. Can share just the comment. So very early on, I worked with MD, and he just tell me, said, look, these days, so we have, every hospital have a different EHR system. He say he actually is burdened by EHR. He say, well, in the old days, it's very simple. He spent more time with the patient, but these days, he spend a lot more time with the EHR than with the real patients. Then his question for me is, as a statistician, say, can you, let's say, provide some tool, maybe even a table, a figure, or illustration, one page that you can quickly summarize over the, because otherwise he said he doesn't remember overall. He said, really, I think this is something that's very useful for the MD.
So, very good question. That's my ongoing project. So we want to work with the VA to actually develop a search. I want to know what's going on with this patient. I can allow the physician to say rheumatoid arthritis. If you just click link to the EHR, it should do a summary for you. What are the key medication? When do they start? What other comorbidities you have? We actually developed the first prototype already, and we're trying to work with the VA to see. The one great thing about the VA, they care a lot about the veterans. They also want the best care for them, and that's like I asked a few clinicians, what is the thing that you want the most at this moment, given AI tools? That's when there was someone from the National Academy of Medicine to give a keynote speech. She talked about AI. She talked about data is the future oil. Like it's such a good commodity. But I think we actually asked a clinician. They have exactly the same thing. I don't have time to sort through so much information and to figure out how do I figure out which code, right? So yes, we are trying to see. Based on knowledge graph, it's actually very easy because you know what you should be looking for if you say what you want. Because sometimes the patient has too much information.
Thank you. So we don't have much time, but we have lunch and break and afternoon discussions. So we thank Tianxi for such a stimulating and visionary presentation, very inspiring. So our next speaker is Dr. Xinzhou Guo, who is currently an assistant professor in the Department of Mathematics from Hong Kong University of Science and Technology. And his research aims to develop novel methods to analyze subgroups with clinical studies, which will help inform precision medicine effort for better predict, treat, and manage diseases.
Okay. Okay, so thank you for the kind introduction for Professor Zheng, and it's my great pleasure to be here to meet many of my senior friends and colleagues. And Tianxi already gave a very fantastic and insightful overview of the application of EHR and some of the recent development. So for this lightning talk, I will just touch on the problem from the special angle, the subgroup analysis. So subgroup analysis is an area which has been developed for a couple of decades, which is routinely based on randomized control trial. And in this talk, I will briefly discuss the limitation of the classical randomized control trial-based subgroup analysis, and discuss the potential benefit of using EHR in analyzing subgroup, and the remaining challenging and what statistician can do to make this come true. Okay, so first a brief introduction of electronic health records. So electronic health records is a systematized collection of patients' medical history. So it contains very wealth information, and it is much easier to access, and it is usually contains a much larger study cohorts, and it can be multi-site study. So electronic health records has been applied to do the phenotyping, risk prediction, and causal link, and etc. So one of the classical problem about the causal link in drug development is called subgroup analysis. So subgroup analysis is the analysis of treatment effect within subpopulation. It is a very powerful tool in drug development. Why? Because a treatment may not be effective for the overall population, but it is often found that it might be effective for subpopulation. So how do we conduct subgroup analysis in practice? The gold standard practice is to evaluate the subgroup based on randomized clinical trial, and most of the existing clinical study, they do subgroup analysis in this way. However, this gold standard practice might come across some problem in practice. So here is one example. So this example is about the adverse effect of statins. So statins is a very widely prescribed drug in treating hypertension. And statin usage is potentially associated with the increased risk of type 2 diabetes for certain subpopulation. And there are many, many papers. And also researchers conduct many randomized controlled trials. But today, there is still no robust evidence. So why? Because the first reason is that in the randomized controlled trials, they have limited biomarkers. So you can only look into small number of candidate subgroup. So people might argue, okay, in this subgroup, you don't find any adverse effect, but for the others, what will happen? But you don't have such biomarkers. And the second reason is that in randomized controlled trial, it is very expensive. And recruiting the patient in randomized controlled trial can cost you a lot. And often the case that randomized controlled trial, it is power for the overall population. So in a subgroup, usually they don't have enough power. So if you don't find any adverse effect, the regulatory agency or the other researchers might ask, is it because you don't have enough power? And the third is about the generalizability of the randomized control trials. As we all know, the randomized control trial might not be representative to the real-world patient demographic information. So in this case, people might argue, even if you find some adverse effect, is it just can it be generalizable? Is it a trustworthy evidence? So with respect to all this limitation of using randomized control trial to analyze subgroups, a very natural idea is that can we use the EHR? Because we already mentioned that EHR will contain much wealth information and you will have a much large study cohort. However, to answer this question, we need to take a closer look. So first, yes, using EHR have some advantage. First, in EHR, we can link the EHR with many different data sets, including the biobank. So we will have numerous biomarkers. And as we all know, if we want to define the subgroup, we need to have enough biomarker. And the more biomarker we have, the more subgroup we can look into, and the more evidence we can build about this heterogeneity. And the second is that, as we just mentioned, the subgroup in the EHR, usually we have much larger sample size, so we can address this high-cost problem in randomized controlled trial. And actually, if we just look into the randomized controlled trial, it would be very hard for us to get thousands of samples in any subgroup. However, with EHR, it is very easy for us to get enough sample to power our study. And the third is that the randomized controlled trial, it is a relatively small cohort. So in EHR, if we have enough EHR from multiple sites, it might be closer to the real-world patient demographic information. So it is a much larger cohort, so it can be used to address the problem. However, this is the potential benefit of the using subgroup analysis on EHR, conduct subgroup analysis on EHR, but there are still some remaining challenges. So these are some problems we need to address if we want to use EHR in analyzing subgroup. And we need to develop a proper statistical method to address this problem. The first problem is I just mentioned. One benefit of using EHR in subgroup analysis is that we have a lot of biomarkers, so we can look into many subgroups. And however, the EHR, although we have many biomarkers, however, the biomarker might be unstructured data. For example, it might be the physician's notes. And also, it might have many missing data problems. So for example, some of the patients, they don't have enough information. So how do you group those subjects? That would be an open question. And the second is that, as we all know, EHR is an observational data, and it contains high-dimensional covariates. So how do we estimate the subgroup effect accurately or in a scientific way? That's also a very challenging problem. And the third is that EHR might be stored in multiple sites, and the data might not be transferred publicly across different sites. So how do we conduct integrative analysis on subgroup? Because we probably need to follow some privacy constraint. And in the end, certainly there are some interplay between the classical subgroup problem and EHR. So for example, the subgroup selection bias and non-regularity. So non-regularity means that when the boundary of the subgroup is not smooth, then what will happen? Then the inference usually is very challenging. So if the EHR, for example, if we use some unstructured data, or if we have some missing data, then how do we define the non-regularity in this case will be also a challenging problem. So, and these are some open questions we need to address. Okay, so in 2022, together with Tianxi, we published a paper to propose a new data analysis pipeline to study the adverse effect of statin based on EHR. And so the first 2 points are the potential advantage of using the EHR. The first is the wealth of information and easy accessible of EHR. So we can link the EHR with the partner health system biobank. So this will allow us to look into the genetic subgroup, which is often not feasible in randomized controlled trials. And second, in this EHR data, we can include 13,000 patients in total. So this can help us to achieve higher power in subgroup. And certainly these are two benefits, but as we mentioned, to make the subgroup analysis on EHR come true, we also need to address some problem and develop a proper statistical method. So the third point and fourth point are what we developed. The first one is about the missing data. So in this EHR data, it not only missed some baseline covariate, even the treatment variables, there are some missing data, and also the phenotyping, the outcome also has some missing data. So we need to use surrogate treatment variable and multimodal automated phenotyping to address this missing data problem. And in the end, this data is observational data, and the classical subgroup selection bias problem we also need to address in this high-dimensional observational data. So we developed a high-dimensional bootstrap collaboration method to address all these problems. And with that, we can have a more robust evidence about the adverse effect of statins. So in our paper, we claim that the adverse effect of statin usage for developing type 2 diabetes is marginal for the overall population, which means that, okay, it looks fine for the overall population. But we do find that taking statins significantly increasing the risk of developing type 2 diabetes for female patients with high genetic predisposition to type 2 diabetes. So that means for female patients with high baseline genetic risk to type 2 diabetes, we need to be more careful to prescribe statin, which is a very widely prescribed drug in treating hypertension. And we can see that all these findings might not be possible without using EHR data. First, the subgroup finally we look into is some kind of like genetic subgroup. So that's only possible when we link the EHR data with the partner health system data. And second, this data is large enough so we can power this study. Okay. Okay, so there are many other applications about using EHR data to look into subgroup. So for example, some people will use the EHR data to identify subgroup of high-risk veterans for future hospitalization or death. And that's really important because usually in randomized control trial, you only have some about your disease information. But about the high-risk veteran for future hospitalization or death, you also need to include some social economic information or the behavioral information, which might not be stored in the randomized control trial. And also some researchers identify subgroup with heterogeneous treatment effect of DTG-containing therapies, and they use the EHR to power this study. And also, some researchers analyze subgroup rates of suicide. So this kind of study might not be feasible. This kind of prediction about the risk of suicide might not be feasible by running a randomized controlled trial. And we believe more will become in the future about using EHR to better understand the subgroups. Okay, so a brief summary. So first, the prevalence of EHR provides unique opportunity to better understand subgroup. Routinely, we are doing subgroup analysis based on randomized controlled trial. However, the randomized controlled trial have many limitations, including the low power, the generalizability, and also the limited biomarker, which will limit our looking into the subgroup. And the second is that although we have many potential benefits of using EHR data to analyze subgroup, there are also some challenging because of the unique characteristic of EHR and its interplay with the subgroups. So to address this challenge and make the subgroup analysis on EHR come true, we need to develop a proper statistical method to utilize EHR in subgroup analysis. And in the end, we can see from our example, subgroup analysis on EHR can help facilitate evidence generation in drug development and regulatory decision making. So like the statin example, there is no robust evidence for many, many years, although there are many guesses it is potentially associated with type 2 diabetes. However, simply relying on randomized controlled trial, we cannot come up with robust evidence. But by using EHR, we have a better understanding about the adverse effect of statin. So in the end, what statistician can do by better utilizing EHR on subgroup analysis? So I think one suggestion or one lesson we learned from this research is that we need to look into some example existing for many, many years that the randomized controlled trial cannot address. And we should try to look into whether we can use EHR to better understand the problem and address the problem. Okay, thank you.
Do the same. We will switch speaker with the same time take questions.
Okay, great. I'm glad I got to ask you a question. So I'm talking about your example with the statins. So that was, what you did was you did an analysis for one EHR system and one particular source of genetic data. And I was wondering, how do you show replicability, trust? In other words, what your goal is that this will eventually get into best practice guidelines. I mean, that's the game here. So what next steps do you have to take to get into best practice guidelines?
Yeah, I think, thank you, Susan, for your wonderful question. So I think that's a very important next step, that we need to generalize this EHR data to more broad system. Yeah, so now if we just focus on one system, then that would be probably the evidence we generate might not convince all the stakeholders in this area. So another potential issue we can address that is to try to combine the real-world evidence and the randomized controlled trial, because now actually, even in statin, there are already many randomized controlled trials. So how do we combine these two and to study whether it is consistent to each other? I think that would be a potential future direction to have a better practice.
And you'll get credit for that work. I mean, as a statistician, it's worth it for you to go down that path.
Okay, thank you so much. Yeah.
So maybe I turn it off. Oh, that's okay.
Guys, can I have the slides?
Okay, so it's my pleasure to introduce our next speaker, Dr. Jingfeng Zhang from Florida State University. And he has a very broad research portfolio that covers AI-powered biological text mining and knowledge discovery, and understanding the sequence structure function relationship of proteins, omics data, omics data analysis method, and cancer genomics and precision medicine.
All right, thank you for the introduction, and thank you for the invitation to the workshop. I will start with a brief introduction of how we started our AI research, which probably will help my discussion of these common topics of this workshop. So yeah, our journey to our AI research, Bell Creative Challenge played a very important role. So it's a challenge for evaluating methods for information extraction in biology domain. The organizers manually read some text, they label that, and then they give the participants some of the data at training, and then they hold some data at test. So it's a kind of blind test, rigorously evaluate a method developed for that problem. Actually, we have been working on information extraction for some years, starting from 27. At the same time, Bell Creative Challenge started, but we have never bothered to participate in the challenge. We're just like many statisticians, did our own thing. You know, we test our method on benchmark data, it performed well, we publish. And then in 2017, that was Bell Creative Challenge 6. And I thought maybe we should try it, see how our method performs. And it turns out our method didn't perform really well, because on that challenge, we were actually invited to give a talk in that workshop. But one of the organizers actually told me that, all the teams are using deep learning, and you are good, you are using machine learning. And I was kind of a bit embarrassed, because it seems that we were invited for being novel in a backward way. So, well, that's fine. But after we came back, I told our whole group, okay, we are going to do deep learning. So we started learning several courses, the whole group, every week. In our group meeting, we present what we learned. We actually do the homework. Yeah, we started learning deep learning really, tried our best to understand as much as we can. And so 3 years later, in Bell Creative Challenge 7, and at that time, BERT already came out, and then we are learning deep learning for quite some time. So we applied that, and we actually achieved the best overall performance for one of the track, chemical entity recognition track. And last year, that's 2023, Bell Creative Challenge 8. And this time, we improved our pipeline, and we also used Llama 2. Actually, Llama 2 came out during the challenge, during the summer. And then once it came out, we also used Llama 2, and also tried GPT 3.5. Well, actually, Llama 2 and GPT 3.5 didn't help as much as we expected. And for this challenge, we actually also performed the best for Bell Red track. That's the track we participated. And for one of the tasks in this track, the end-to-end knowledge graph construction task, we actually performed much better than other participants. Because usually in these challenges, because everybody uses large language model and fine-tuning, it's hard to really differentiate. But for this challenge, I think we really did some innovative work. So finally, we have some innovation to kind of make some more contributions. And we also participated in another challenge called the Lake Coin LP Challenge that's organized by NIH and then NASA. And it was held in around November 2021 and February 2022. So this challenge aimed for testing methods for knowledge graph construction. The organizers, they manually read around 500 PubMed abstracts. They annotated these six entities, diseases, chemical compounds, gene, proteins, etc. And also annotated 8 different relations. And for this challenge, they actually have a handsome amount of cash prize. And we were fortunate to also win this challenge. And after that, we applied our pipeline to process all the PubMed abstracts. More than, I think we update our data. Now it's more than 35 million abstracts. We also integrated data from 40 public databases, and we also analyzed some public available high-throughput genomic data. We analyzed the data, generate some knowledge, and put into a knowledge graph. At the end, we have a large-scale knowledge graph. We call it Bell KG, with more than 11 million entities, more than 40 million relations. We just posted this paper on Bell Archive. And I think it's a kind of good work, because we also designed algorithm for automated knowledge discovery and achieved some very interesting results. But our paper was rejected by both Nature and Science. We tried to make a bigger impact, but maybe next time we're going to try Nature methods. So from, okay, so one more comment. From our experience, I think to make impact in AI research, we should, like you just seen, we should walk out of our comfortable zone. To really, like many people have discussed, really learn, their stuff, to be accepted, right? And then to play kind of their game. Because, they don't really care about our own game. It's not like their game is necessarily better, but they do care the real world problem. They do care whether your method really works or not, right? They design this blind test. That's something we can learn from them. Yeah. Okay, next I will start, discuss these topics. So what will be the next stage for research in this field for the next 5 to 10 years? I can only say what I know. So I think the next important thing would be foundation models in biomedical science. Because I think it's time, of course, many people have discussed this, and I think it's time for this kind of model. It can really address some of the challenges some of you guys have talked about, right? We have a limited data in biology domain, many different fields. But how can we actually make best use of limited data? But we know in NLP, right, they have these large language models. Now you can only annotate a small amount of text data, like all these challenges we participated. For Litecoin, only annotated 500 PubMed abstracts. So that's something a relatively small lab can do. But the model we trained actually performed quite well. I think at human level, human annotation level. So then we can kind of apply the same idea to train a foundation model in biomedical science so that we can transfer the general knowledge in this foundation model and then use limited data to address many of important of the biology problems. And also with this foundation model, we can integrate heterogeneous multimodal data. We can integrate, in our study, we have data from literature, and then we also integrated data from genomic data, and then we can have image data and EHR, And we can, as we know that if we ask ChatGPT about some biomedical questions, it's really not good. We tried it, but with a foundation model, we can actually develop a general question answer system for biomedical science. Yeah, like I mentioned, one important factor for foundation model is now we can actually extract knowledge in literature very accurately. And we already have human level information extraction methods. Then we can build a knowledge graph, a high quality knowledge graph. And with this knowledge graph will form a solid foundation for this foundation model. And then in addition to that, we can, like I mentioned, we can add a lot of other data. And then if you look around, we already have all the expertise, right? We have people good at transcriptomics, gene expression, single cell, epigenomic, GWAS, EHR. And as a team, I think that's something we probably can actually work on. And so next, what would be the most exciting and pivotal breakthrough that AI and statistics could lead to that will change the practice? From my experience, of course, I am advocating foundation models. But another thing I think is really important is we have to be able to predict with confidence. Yeah, in a way that we need to give a good estimate of uncertainty and confidence level of predictions. And so in the past, about a decade also, the computer scientists they're driving the field, right? Because hardware and then algorithm. But the next wave of AI research, I think, will be mostly data and then real application driven. And for these problems, being able to assess this uncertainty is really important. And I think that's what our statistician can really make an important contribution. And for example, Tianxi mentioned hallucination, right? I was talking about ChatGPT. And when we test ChatGPT, indeed, it has, make a lot of strange errors. But if we wanted to write an essay, it's okay. But if we want to use that for some serious application, hallucination can be really dangerous. And then we have to really have a way to measure how well it actually predicts. And what is the most important? Okay, I guess I have talked about that. Yeah, I think this is being able to estimate uncertainty or confidence level is really something we statisticians can make a very important contribution. And this is definitely right now an important problem. How could the individual statistician get started to contribute? And I mentioned this a little bit. Okay, so we have discussed this quite a bit, and then as many of you have mentioned, we really need to learn the domain knowledge and to be good at that particular area, to be the scientist. I will skip this. I think you discussed this also. I will skip this too. So finally, I would like to propose an open challenge problem. So this is something we want to actually discuss, right? To build a biomedical foundation model together, the team. And we can first form a team of researchers for those people who are interested in this, and then we can identify some smaller challenges or some subtasks. And we can form smaller teams to work on these smaller challenges. And then we can evaluate our progress every year if we have a next one in next year. And we can publish our initiative and then all the progress so other researchers they can join this effort anytime they want. Okay, all right, thank you.
Speaker will take questions. The next one is Jianfeng.
Yes.
I think this is a great idea, but a very good idea. But I do have a question about this foundation model.
Yeah.
Suppose you only have those typical tabular type of data, so many different tabular data without a lot of text description. Do you think you can, how can you use foundation model for those type of data? There's no image and no EHR, no description. If I only give you numerical tables, that.
Well, actually, table is structured data, right? So from table, if we can extract entities and relations, we can just incorporate that knowledge into the knowledge graph, and that will be part of the foundation model. So table, if you have table only numbers without column row names, of course, it's useless. Otherwise, I think table data can be used very conveniently.
Without first analyzing the table.
Depends on what your table is. Yeah. If your table just say gene experiment data, right? Yeah. Then you need to analyze because that's not knowledge yet. Yeah, for example, what we did, we analyzed high-throughput genomic data, but we didn't actually just put raw data into knowledge graph because that's not knowledge. For example, when we analyzed that, we did differential gene expression analysis. So that's to infer gene-disease relationship, right? And then from that data, we can also infer gene-regulatory relationship, so that gene-gene relationship. So that knowledge, after analyzing the data, can be input into the knowledge graph, and be used as part of the foundation model,
So thank you. We probably need to move to the next talk, and then maybe we can continue the discussion over the break, because I definitely have questions too. So then our next speaker is Dr. Jianfeng Feng, who is a professor of computer science at Warwick University, and his research covers computational biology, computational psychiatry, abstract and biophysical models of single neuron and neural networks, stochastic and nonlinear dynamics, data mining, and mathematical physics. That's a mouthful, so looking forward.
Well, thank you. That's my homework, so I will answer this question later on. And originally, I was assigned by this guy to yesterday morning, but he kicked me out. So I'm not talking in this session. So before I can answer this question, or maybe I tell you a little bit about what I'm doing in Warwick and in Fudan University. So we are a group basically really working on experiment. So I have a team, experiment team working on experiment, and I will tell you a bit about what's reconstruction and working on theory as well. So I tell you my background, what we are doing at the moment, and then try to answer that homework later on. Okay. So that's what we are doing. from experiment side, actually, we are a team, as I mentioned yesterday, we do collect a lot of data ourselves. So we spend a lot of money, a lot of efforts to collect the data from genetics, brain image up to behavior, and then we do develop a lot of machine learning approach to deal with all data. And this is actually my publication from last year. And I'm on the driving seat. If you want to tell, I'm really the senior author for possibly half of the publication, more than half, I think. So we really work on biology from experiment side and very closely. And while myself, I'm a biologist as well, in a sense. So that's from experiment. We do experiment from very, very basic biology issues. And then so look into all these mental disorder from schizophrenia, depression, and autism, AD, etc. And so from experiment, from learning biology, and based on biology knowledge, so what we did for the past few years, starting from a few years back, and what we try to do is we want to build a digital twin for the brain. So that's the thing I spent a lot of time in the past few years. So we try to set up, so we have 86 billion neurons in our brain, so huge, and we have 100 T parameter, 100 trillion parameter to be estimated to construct this model. So based on the data, so we spend quite a few years on it, and actually we use one of the largest computer during the time. So we use 10,000 GPUs, try to reconstruct this model. And at the moment, that's what we have actually. So as I mentioned, for digital twin model, we have to find these 100 trillion parameters. It's a connection between 86 million neurons. So that's possibly the largest model at the moment in the world. Possibly, as you know, ChatGPT-4 possibly have 1 trillion parameters to be estimated. So how can we do it? It's a funny thing. We're using data assimilation, essentially common field approach. So we estimate all these parameters, and that's what we did already with FMI data and with MEG data as well, and for zebrafish as well. And we are working on these two models. So we try to build a digital twin for the brain. And if you think about mathematics or applied mathematics, the most successful mathematical approach or branch is fluid dynamics. I would say computational mathematics. So that's what we are doing for the past few years. We want to analyze data, understanding biology, and then come back to math or statistics or probability, try to build the model there. Well, the theory part, maybe I skip it. We try to build stochastic computation rather than deterministic computation for the brain at the moment. So that's my homework. So I start to answer. Yeah, I just give you a basic background of what we are doing in Fudan and Warwick there. And so the next stage for the next 5 or 10 years is the first question. To me, I think, as a applied mathematician or statistician, or maybe more probabilities. Yeah. So for me, what we try to do at the moment, I think, in the next 10 years, if we can build a virtual you, that will be my dream. Okay? So using mathematical approach, use a statistical approach. So as I mentioned, for example, we try to build a digital twin brain at the moment. And so use all this data we have, and we estimate this 100 trillion parameters there. And so if we can have a brain and a body of virtual you, then we can do a lot there. Yeah, so that's my dream. That's my blue sky dream for the next 5 to 10 years, okay? So all this model, of course, based on biology fact and first principle, we have to estimate a huge number of parameters there. How can we develop a statistical approach or mathematical approach to reverse engineering to estimate all these parameters? I think that's a huge task. And some of Hongtu's stuff, for example, he tried to link a brain with body, with heart. All this thing, might be help us for our purpose, I think. So that's my dream. And if we have this virtual U, I think we can change a lot in our area. For example, we can. That's one of the things we are doing. For example, we try to using our virtual brain to test all this brain-machine interface. Yeah, so if we put one electrode in your brain, what happens essentially? Yeah, like a DBS, for example, some of you will talk about. So that's why I will never allow anyone put the electrode into my brain. Yeah, but that's my digital twin brain, so I can put whatever you want there. Yeah. To test what's going on. And for example, another thing, for example, we can use for the drug experiment, for example, for the data there, we can manipulate the digital twin brain and see what's going on there. So I hope we can really change the practice in brain science, for example, or brain disease, rather than doing all these wet experiments. We can do the dry experiment rather than carry out all these. And the most important question, open question to me, I think I mentioned to Martin yesterday as well. So one of the things I think in AI or in all this model or in my model that I haven't figured out another thing I want to do next. How can you implement a biologically realistic learning loop there? At the moment, the AI is basically BP, which is too trivial to everyone sitting here. Yeah, I did have an argument with Jeff Hinton, So I told him that's, first year undergraduate students, we can do it in math department. Yeah. So how to implement this really biological learning loop from our model or from biology, and then we can go back to AI, say, implement this learning loop in AI system. And we can go beyond the current AI, maybe go to a little bit of AGI, general AI. So that's I think that will be one of the very important questions for, we say people sitting here from statistics or from AI side. So that's my three questions. And the final question you guys want me to ask, to answer, I think I should. So I put a little bit of Chinese here for you guys. I know that we don't have many foreigners here, but I already summarized what's going on in our Chinese video there. Yeah, so I can say, can you hear me? Oh, sorry, is that a sound available? No, not now. I recorded it. Of course, it's 1 or 2 years back. I think we have a ceremony for our, alumni forum. The first one in statistics, actually, back to Peking University. Can you? I'm sorry, I should ask you a bit earlier. Do you have some? No, I don't hear anything there. Is that some? Oh. No? No, none of this. You don't answer? Well, I should check this earlier on, but sorry for it. But, a little bit, okay. Yeah. In Chinese or in English? Well, we have a first alumni forum in statistics, and they invited 3 of us back to Peking University, Samuel Kuo, and Liu Jun, and myself, 3 of us, talking about in the first forum about statistics. I think it fits this conference very well, and conclusion is that we have to work problem-driven in statistics rather than say publish a method only for method. So so that's a key thing. They ask about what we should do in statistics to accelerate all this progress. And this guy come up say he want to do real data. So if he can be in China, he will visit me more often, into Shanghai. So that's the message I want to give. Yeah.
非常引人入胜，所以我们稍微时间推后一点，主要是对君和 Sam 在美东那边时间比较晚啊，所以我们尽量的这个就是discussion 这个环节，我们想讨论一些，就是说首先可能我大概也这个问了一下，就是比如这边大家感兴趣的一些问题啊，关键性的一些讨论，可能我这边 summarize 一下，然后这个之后可能参会的这个老师和同学，如果有这个包括刚才3位老师讲的这个报告里面的一些学术性的讨论，还有关于这个统计学的一些统计学与数据科学的一些更 general 的这个 discussion。对，其实这个也是推动这次校友学术论坛的一个初衷，就是说我们从这个尤其是国内统计学科在这个现在包括数据科学，包括交叉研究各方面都很需要这个有进一步的这个发展和推动。就在这方面来讲，所以说今天的这个第一期我们这个学术报告也是主题也是集中在这个不光是统计学，包括数据科学，还有这个更跟其他学科领域更广义的这种交叉研究上，在这方面的一些主题报告，所以说也想请这个3位这个我们的杰出校友君 Sam 还有冯老师，这个大家聊一聊，就是说在现在的这个时代背景下，我们统计学 in general 或者是国内的这种统计学科，我们怎么样能够抓住这个时代的机遇，然后推动我们学科的自身的发展，还有和别的学科的一些深度的交叉融合。君还在是吧？
就还行的。
不好意思，这个时间拖的有点晚了。对，就是说这个看3位这个给大家一些这方面的这个前瞻性的一些建议和指导性的这个comments。
我这个先抛砖引玉吧，我觉得很难有真的什么前瞻性，这还是 old wisdom。我是非常欣赏那个冯建峰他们做的那一套东西，我觉得那是正路，就是说真正的投入到这种大问题里边，然后去想办法去做 leadership， 然后真正的去跟这个就是生成数据的这些人多接触吧。虽然咱们都不可能所有人都做到建峰这样的哈，但是咱们至少可以做到建峰的队伍里掺和，或者做点搞点数据啊什么的，然后再发展一些理论出来。我觉得这个还是一个比较有影响的一个做法。当然像 Sam 他们也是跟很多这种实验科学家都有非常深刻的接触。我还是觉得我个人当然做 research， 虽然现在有时候理论啊都做点，但是很多的那种 insight 呀和那种问题啊来源还都是非常实际的问题。所以我决定，我要是再多回国的话，我肯定要多拍这建峰的马屁啊，这个东西。钱是小事，这数据还是很有重要。
来上海。Yeah. That's my final comment to come to Shanghai.
Yeah.
Okay.
Yes. So I want to translate the main takeaway message from the video is we need to become best friend with Jianfeng so that we can get onto his big data wagon and have access to the whatever digital twin or foundation model or all the big data. That's what Jun says.
So I have more like comment. Okay, so it's a great work. So I'm also working on the neuroscience project. What we're doing actually, we're still studying the rats, the episodic memory, how the memory form over the time, and how they remember the things over the time, like use the rats to smell the odor. Yeah. So I want to say something about that. I think what imagine things like why the things we can imagine in the future. So these days we talk about drug discovery, immune system, but for the brain disease, we should think wide. I think if we can understand the licensing mechanism, then we're able to, let's say, do the device, insert the 3D chip in the brain, especially for Alzheimer's disease. Pretty much there's no cure, right? You cannot reverse Alzheimer's progression. But something more, it's very terrible for a lot of Alzheimer's. Do something medical device, more like science fiction type of things, insert a chip in someone's brain.
I mean, say, one of the advantages for working on the brain science is, we have feedback as well. So we can really look into the future of AI. It's not only we can, say, deal with some of the biological problems. And another thing I always found funny, when I talk to all these people want to solve the AD problem. Impossible. What in my mind is you never think about you will solve this problem, but if I can improve the treatment, for example, by 5%, I have enough, right? Or depression. For example, we do work on a lot on depression and Alzheimer's disease as well. So my belief is, no, you cannot solve it, but if you can improve it by a certain percentage of the treatment of depression, for example, that's enough for me. Right? So I think if people, when they talk about the disease, they always say, we can solve the problem. No, it cannot. Impossible. That's a very complicated issue. If you really look into the data, working with a clinician, working with a biologist, you will realize it's a very, very complicated thing. But I think as an applied mathematician, or statistician, what we can do is maybe we can develop some virtual organ, essentially. That's what we, essentially from math, from applied math, what we are doing here. A lot of, ours is a flight or submarine. So we simulate it first before we really into practice. So that's my dream. We build a kind of a digital twin at the moment and try to put it into real use, real applications. Okay.
Yeah. So before we jump into the next lightning talk, I want to explain a little bit because we're all watching our watches and then try to see where things are. So after the next lightning talk, we'll wrap up the session and then take a very short break and move into another very exciting keynote, then followed by lunch when we come back from lunch. And we will finish the lightning talk of the second session and then plan out the breakout discussion, because I think now we are getting very excited about, passionate about research discussion. I think there are a lot of opportunity to connect, to discover, and to plan, and then discuss the next stage of AI research. So our final lightning talk for this session is Dr. Lexing Li from UC Berkeley, and he's a professor of biostatistics there, and he works on statistical methodology for high-dimensional data analysis and application in neuroimaging, computation biology, and biomedical research.
Thanks. Yeah. First of all, I'd like to thank Tian and Hongtu for putting together this wonderful workshop. I think this is the smallest workshop I ever attended, but quite stimulating. I enjoy it a lot. I decided to talk about sort of two examples of some of the work we have been doing here. The first one is more like a specific case study, showing how we use some deep learning tool to help solve some or answer some classical statistical problem that is doing some kind of inference for directed graph. And the second is some kind of actually a series of ongoing works, particularly deep brain stimulation that we are working on right now. Actually, both works are in collaboration with Dr. Chen Chunshi from London School of Economics, who is also here in the audience. And we all know, deep learning is exploding, and we always ask ourselves this question: how shall we deal with it? And one way to put it is we can ask how deep learning can help our research, and also how our research can help deep learning. This first case study is more about the first question: how to use some deep learning tools, some very flexible, powerful learning tools to facilitate some classical statistical inference problems. As statisticians, biostatisticians, we are always interested in this uncertainty quantification inference. So the particular tool I'm going to mention here today is using this deep generative learning. There have been a number of different methods. There's generative adversary network scans, variational autoencoders, more recently diffusion models, and also transformers. What we want to first talk about in this example is how to use deep generative learning to help this testing problem for directed graph. So our target is kind of simple, well formulated. I have a directed graph. I want to know if there is a link, or more particularly if there is a node from a link from node K to node J. So that's kind of the hypothesis we want to test about. The model we are working with, the working model we are using. Oops, sorry. Go back. Yes, thank you. So the working model we are using just some additive noise model. So here we want to say we do not want to only restrict to linear type models over here. Of course, this question, people have been studying this, have been thinking about this for years. Penalized estimation is a quite useful tool to partially answer this question, but at the same time, we also know estimation is not the same as inference. Bayesian network is another very popular solution, but it often suffers from some computational challenges. As a result, the network size is often very limited. And there have been some recent proposals doing inference for DAG, but usually assume linear type associations and also assume RID data. We want to go beyond this a little bit. So we want to actually, already mentioned, do not have to assume linear type associations. And as we were seeing a minute, a big component of this inference for DAG is conditional independence testing. But it is not only conditional independence test. Okay, there's something different. And we want to also work with some kind of time-dependent data. So in particular, our applications come from neuroimaging studies. We have the, multiple subjects or multiple trials. Each subject we observe this brain wave type of data, so essentially time series type of data. Okay. So we try to use some deep learning tools to help answer this question. So again, just some very high level summary, key points, what we have been trying to do. And the first observation is, again, this testing problem is closely associated with this conditional independence testing, but however, this conditional set, on one hand, should definitely include the parents of the node J, but it cannot contain any common descendants of the J and K. Okay, that's a very crucial observation. So this observation allows us to use some technique from conditional independence testing to answer our question, but a very important difference is we have to have a good estimate of the DAG structure at the beginning so that we can exclude those common descendants. Second observation here is this is the key component of our test statistic. And then we actually, this H is some kind of transformation function. We use a lot of different transformation functions to improve the power of the test. So in principle, we can, just estimate its conditional expectations in this key quantity of the test statistic, which is just a supervised learning problem. However, because we use really a lot of transformation functions, in our experiments, we use thousands of transformation functions. The computation is kind of tractable. As a result, this is where this deep generative learning kicks in. So we learn the conditional distribution. And if we can learn this conditional distribution nicely, then we can easily compute these conditional expectations. Okay, so this is where this deep generative learning really helps us. Of course, in addition to that, we also use some deep learning tool to learn the DAG structure at the beginning, and we also use some kind of a deep neural network to do this supervised learning task as well, this single conditional expectation. Now, as statisticians, we are always interested in, does this inference, this test really works? We want to make sure the size is well under control, and hopefully it also has nice power. And this is kind of another kind of a key component of this study. So we build this, we construct this test statistics that is doubly robust. And because of that, a very interesting observation here is we are using deep learning methods, which are essentially some kind of non-parametric learning methods. Their convergence rate is slower than the classical root n. However, thanks to this doubly robustness property and some other kind of properties of this test statistic, we show that the test statistic is still able to achieve the root n classical convergence rate, which is very crucial because this would then make sure we can control the size and also has some desirable power property. So what, again, essentially what we are doing over here is we are utilizing those deep learning tools as some sort of flexible, non-parametric learners, and then we try to build our test that can still achieve some parametric convergence rate. Okay. And we did this under the sort of a symptotic framework where either the number of subjects diverge or the number of time points diverge. Okay. We apply this to some kind of brain connectivity example, and we made some interesting findings. I think in the interest of time, I just skip this example here. And then, so again, what we have been doing, as I sort of briefly mentioned earlier, just some example showing how we may utilize those highly flexible, highly powerful deep learning tools to help answer some classical statistical questions. We have done a bunch of other related works along this line. For instance, general conditional independent testing problem or testing the Markov property in time series data, which are all kind of very important statistical inference problems. Okay. Now looping back to this more general question, how to embrace deep learning or AI into our statistical research, right? And there are so many developments in the past few years, but this computational or practical feasibility is also something we need to take into account. People mention like foundational models, those large language models. Unless you have a lot of money, have a lot of GPU, the computation is not trivial at all. So that is also something we need to take into account. Another question we always want to ask is what kind of unique contributions can statisticians, biostatisticians bring to the table, right? I think many of the speakers already gave some good answers here. We used to think, the machine learning or those computer science methods, they are black box, so lack of interpretability. We are good at interpretability. We are good at some uncertainty quantification. But I also want to mention that things are changing very quickly. A lot of people in computer science community are also working on this, interpretable deep learning, right? This XAI. So what I feel, I think one thing we can do, partially answer these high-level questions home to and imposed earlier, is I think we really want to do some real impact, real application. So this is my second example. Again, just a high level. This is a series of works we have been doing in the past few years. This deep brain stimulation. This is a very exciting research direction. It's also part of the bigger effort of this brain-computer interface. Okay, so we spent a lot of years talking to the neuroscientists, neurosurgeons on this problem, And now we are developing kind of methods, writing papers and proposals. So simply put, what deep brain stimulation is doing is, sounds very fancy, by the way. We open up the skull, so we drill a hole on the skull, we place the electrodes inside the brain. So this is a highly invasive technology. Actually, to make things even more interesting, the position of those electrodes are very, very important. So to make sure we place the electrodes at the right place during the surgery, we have to keep the patients awake. Okay? So we need to, the neurosurgeons need to talk, interact with the patients. Okay. It sounds complicated, fancy, but this technology actually has been quite mature. But people are trying to, have been doing right now is once the electrodes are placed, the physicians assign those kind of control parameters. For instance, how much stimulation to apply to the patient every day, for how long, and what amplitude. So all those parameters are fixed. Okay. Now we feel we want to do this in a more adaptive way, very naturally, because these electrodes can also collect all these neural signals, feedback from the patients. So intuitively, if the patient is having some less severe symptom today, we probably want to apply less stimulation. Or the other way around, we probably want to apply more stimulation. So naturally, if we think of this problem from a methodological perspective, this is a reinforcement learning problem, right? We want to adaptively come up with some optimal strategy to help improve the patient's health outcome. Okay. But then there have been a lot of papers, a lot of new methods, new algorithms on reinforcement learning on one hand. There is this huge demand from neuroscientists, from neurosurgeons on how to do this adaptive deep brain stimulation. But the reality is there's a huge gap. Okay. There are a ton of practical questions. For instance, the reward, we need to observe the reward if we want to do reinforcement learning. But in a lot of those situations, these applications of deep brain stimulation, the reward is not fully observed, or is not even well defined. For instance, in Parkinson, we kind of have some better idea what kind of reward we want to achieve. But for other neurological disorders like depression, we do not even know what is the best reward over here. Another practical challenging over here is this device. We also implant some device into the patient body. So this device is acting like this kind of controller, deciding how much stimulation to apply. But this device is very simple. It is not a computer. It cannot do those fancy deep learning algorithms at all. So we have to do some approximation. So what I want to say here is there are all these practical constraints. So if you want to make real impact, make this really useful, some really useful adaptive RL solutions for deep brain stimulation, I think there's a lot of work we need to do, and we can contribute as statisticians, biostatisticians. So we are actually, as I mentioned, doing a number of different projects trying to address many of those practical challenges. And I feel this is, in my opinion, probably a useful way to incorporate deep learning AI into our research. And at the end of the day, I think we all want to kind of advance the science in the end. Okay. Yeah. I think that's all I want to talk about. Yeah, stop.
I think if you're talking about a human, DBS, relatively simple because you only have one electrode there normally. And so what we are doing at the moment, of course, we put more electrode in. For example, if we want you sleep at the moment, so how can we say stimulate a different area so you can get sleep at the moment? So that's what we are doing actually. So we are doing this for monkey, for example. So in monkey, we can really insert a multi-electrode in all the brain, and we can control. And that will be really a feedback control task for reinforcement learning. How can you develop the best parameter setting for not one electrode, but a multi-electrode. So for example, so you can sleep at the moment. So that's what we are doing actually for monkey. So we do implement many electrodes there.
You're right, the number of electrodes right now is not very huge, but still we usually implant 4 to 16 electrodes. Yeah, but sure, yeah. But setting that question, that part aside, there are a lot of common challenges. Like another issue actually you mentioned that is there are a lot of control parameters, right? How long, how much amplitude, but then where to place those things, a ton of control parameters. It's very difficult to, to experiment with those parameters, especially on human. So that's also a challenge we have to deal with. Yeah, and of course there are all sorts of ethical issues as well, etc. Yeah.
Thank you. Yeah, I just have a quick question. So what I have learned about neuroscience is that the concept of functional segregation and functional integration, right? So so when placing the electrodes, how do we decide and how do we go for a specific location? So if you are targeting a specific function, for example, sleep. So as of now, recently we know that not a specific region is filtered to that, but a track or a network of the regions. So how do we cater that problem in this scenario?
So I think my understanding, your question is how to decide where to position put the electrodes?
Yeah,
right?
not just that. I mean, the thing is, like, in order to induce something using deep learning or reinforcement learning, so in different brain regions, in different scenarios, right? Multiple networks, they, for example, the default mode network in the resting state. So what I'm trying to say is, like, not a specific region. A specific region does not do a specific work all the time, right? Mm-hmm. So how do we tackle that in this reinforcement learning scenario?
Okay, yeah, so I think that there's still a lot of open questions here, like in terms of like the positions we were talking about, and this really depends on what kind of disorder we are targeting. For Parkinson, we have much better idea where to position the electrodes. For depression, for instance, for sleep is something we are also working on, try to improve the sleep quality. We have less clear ideas. Yeah, and also like if you think about depression, what do you mean we are really improving the symptoms of depression? It is not actually a clearly or cleanly defined question either. But then deep learning, so again, what we are doing is we try to, first of all, identify those practical challenges, then try to formulate in this framework of reinforcement learning, and then a lot of those deep learning tools, we use it here, there, as some individual components to help, answer some of those questions. Yeah, please.
So these are settings, so this is the type of setting where I would expect to see more MPC, model predictive control, or methods like that. Maybe I could see maybe RL producing some features that the MPC controller might use, but I don't really see RL being used full force. First of all, you're talking about humans, and there is, and as we all know, that MPC, MPC is used all over the world to control like almost everything, cars. But RL or other AI methods can be used to do feature construction and things like, they can be used to assist the MPC. So is that the direction you're thinking of, as more of as an assist? I mean, I know it's totally cool to do RL, but I'm a little concerned about online RL in this setting. Yeah, it's.
You're absolutely right. There are a lot of issues with on RL right now. So as a result, it is not widely used in practice yet. So that is part of the things we want to sort of see if we can come up with more practically useful RL solutions. But another direction we are also exploring right now is doing this kind of hybrid version, integrated version of MPC and RL, right? Exactly as you mentioned, MPC is used everywhere, in autonomous driving, it's kind of, DBS and other settings. So we are thinking maybe RL could help bring some additional, either features or some other additional help to the MPC. So that's also one of the directions we're exploring right now. Yeah.
A quick break right now. I think we should resume about in 7-8 minutes for the next keynote.
I'm Peter Song from University of Michigan. So I'll be chairing the theme 4 at the last theme session of this retreat. The picture? The future. We designed this sort of the theme 4 under the theme of the smart health. This is really an emerging sort of field of the technology and new ways of data collection. And so this is well aligned with translation research and personalized treatment regime. And we know that in the past 10 years or so, there's emerging technology of wearable devices that have, given the rise to the new technology of data collection. And in the year of 2020, there were about $14 billion investment in the Silicon Valley to support all sorts of the startup companies. I was very fortunate to work with one of the startup company, UnoLab, to manufacture this earbud to predict this timing of ovulation to help ladies to increase the chance of pregnancy. So there are a lot of new technologies to help people to improve hearing, to vision, and so on and so forth. And then digital health sort of features would change our world. And there will be tsunami of data coming from all the startup companies, how statistical community prepare ourselves to deal with those data and to be part of this innovation. And that's very important that we have this opportunity to discuss and to see what are the upcoming opportunities and challenges. So I'm very happy to get the approval of this sort of organizers to put this smart health as one of the themes of this retreat. So we're very fortunate to have Professor Susan Murphy to give the keynote. And as she was my former colleague at University of Michigan, and then she received, she doesn't need much of introduction, but I want to make a couple of highlights. She received McCarthy Fellowship 2012, and then be elected as a member of the Academy of Medicine 2013, then elected as a member of the Academy of Science 2016, I guess, right? So then, being her sort of former colleague in Michigan, I will tell you one secret. And Susan played ice hockey. And then, so I think she set up a model from T to C to L, and the perfect pass that Tim mentioned in the morning. I think that we are very interested in listening to Susan's story about her research. Susan.
He forgot to mention that, of course, Shihang abandoned me at Michigan, and of course, then I had to follow her. I think I was thinking about this, listening to the other talks this morning, and this area of online algorithms, this is an area that we need. We have a lot to offer in online learning. Enormous amount, because we live in this world of bias versus variance trade-off. And in the online setting, bias versus variance is the game. It's always the game. And that's underlying everything I'm going to say today. So I just press this out. Uh-oh. It doesn't. Oh. Okay. Maybe I go backwards? How about going backwards? It worked. Okay, so what I'm going to do is I'm going to focus. There's really interesting work in the digital space on the use of sensors to detect, to do phenotyping, to detect risk. I won't speak about that here. I'm going to talk more about closing the loop. And so in the digital interventions in the healthcare arena, this is about wraparound care or ancillary care. So someone is already coming in at regular intervals to the clinic. How do you provide support outside of the clinic? And it's almost always some sort of behavioral care, like adherence to medications, or managing your stress, or helping you be more physically active, and so on. And all these interventions tend to have multiple components. And I'm going to show you some examples of how they have multiple intervention components. And almost every component involves sequential decision making. And the number of decisions per individual over time can be into the thousands. I mean, many, many decisions for each person over time. How are these decisions being made? One way, a variety of online algorithms are used to make these decisions. One type of algorithm that is being used is the reinforcement learning algorithms. There's other types of algorithms just trying to spread out interventions across the day, across risk times. These are also online algorithm problems. I wanted to mention, and you've already seen this today or yesterday as well, there's a lot of non-health areas, online education, enormous interest in using online algorithms in online education. Online ad placement, I mean, this is where you see it all the time. Every time you go to Google, Facebook, people are running different kinds of algorithms on you. Optimization algorithms, large language modeling RL is being used. As supply chain optimization, Amazon uses RL in supply chain optimization. If I get a chance, I'll speak. It's a little different from, we're really lucky in the setting we're here, that in the digital intervention, we have the opportunity to use the algorithm online. Whereas if you go to supply chain optimization, it's sim to real life. They run the algorithm in a simulation type environment, they find a policy, they implement the policy, and then they run the algorithm again in another simulation environment. Here we're talking about online. So we have a unique opportunity here. It's much more online. So the data is the classical data in this setting, SAR, state, action, reward, and I just enumerated what these are. State is different types of sensor data, data from your phone, data from other types of wearables like chest bands, the little earbud thing you were talking about. The action is some sort of nudge or behavioral support that's provided, and that's what, here I just call it an action, and it's the algorithm's decision as to what that action is. I'll show you an example later. And then there's a reward, and this is the algorithm's reward. The algorithm's reward is somewhat related to the health outcome you're looking for, but it's not always, it's not one-to-one. The algorithm, so we're talking about online RL. So here, the algorithm is attempting to learn. It has a certain amount of time. It doesn't know that it's an anytime algorithm. It doesn't know T, capital T, ahead of time, but it's trying, the goal is the algorithm should maximize some sum of rewards. So here's an example. This study actually just went into the field in November. It has two components, which is sort of unusual. That's very few for this setting. The self-monitoring and the engagement component involves this is a collaboration with Procter & Gamble. We're using their toothbrush. And the engagement component is try to help the person engage, have a positive view of the app so that they'll self-monitor their toothbrushing. And you can see the little engagement going across. There's a whole bunch of different types of engagements. These are your actions. The decision times 2 times per day. And the state data comes from the electronic toothbrush, how much the person is actually working on learning how to brush their teeth appropriately. So I wanted to be really clear. You know, there's ways to think about RL which helps you really understand the problem, and it's actually not that complicated. And so in online RL, there's 2 elements. There's always usually 2 elements. The first element is what we understand is a learning algorithm. It's often incrementally implemented. But in my world, it's just it's some sort of statistical fitting model. It's fitting some sort of multivariate distribution, and it inputs the data you have, say, right up to time t, and it outputs some statistical inference for use at time t. Again, it may be incrementally, often it is incrementally implemented. And then the other element, the second element, is the optimization algorithm. So this is a method for selecting those actions at each time. This method inputs the current state, the data that's available at that time. It inputs the information provided by the learning algorithm. It combines these two sources of information and outputs an action. And the learning algorithm has to make some, and people in RL know this, it has to make some difficult decisions. Does it choose an action which helps the optimization algorithm? Does it choose an action which helps the learning algorithm do a better job of inference? Or does it choose an action which says, oh, this learning algorithm is doing great, I have a good idea of what action to use? That's called exploitation. So the second element of the RL algorithm is always trying to balance either helping the learning algorithm do a better job or trying to exploit the knowledge provided by the learning algorithm. So it's not even that sophisticated. It's just simple. Okay. Oh, great. So there's growing realization that when in the use of RL for real life, that it's actually a more complex setting. So, and here's my little picture to show this. So you always have a sequence of implementations. And this is going on both in companies as well as online education and so on. So at each implementation, you can imagine here, in my case, there would be N1 people, and you're choosing, you have some little artificial agent, that's the RL agent. It's choosing actions over time for those N1 people. And then that goes on for a particular amount of time, T1. Then there's a human in the loop. And the human, why is there a human in the loop? It's because this is a setting where the technology is evolving very rapidly. So a new sensor comes out, and you want to use that sensor. All of a sudden, you have different amounts of information you could use. The population is changing. You may go from sedentary people to people with stage 1 hypertension. The pandemic, in our case, occurs. So you have societal changes. All of this comes up with this human in the loop. And so there's a whole sequence, and it's the minute you get into the real life setting, you know a lot of the theory behind RL doesn't make a lot of sense anymore because you're not trying to just learn in one implementation and then you're done. It's just not like that. Let me see, I wanted to make sure I said, okay, I'll just leave it like this. This is the setup in general for RL in real life. As you're going, so I'm going to talk to you about another study, Heart Steps. It's going to come very soon. And we're about ready to go into our 5th implementation. And this is the standard. So these are continual learning settings, and this is the area that RL in real life is moving towards. And in general, it's a continual learning type setting. Here, the upper level involves the human in the loop. That's what I showed you on the last slide. And the lower level can use an artificial agent, an RL agent, that attempts to learn during the implementation, that immediate implementation. So in this setting, the minute you think of it in continual learning, the RL agent is itself part of the treatment now. It's not an experimental design. Its goal is to be, so like in rollout, even in rollout, say like by Kaiser in Seattle, you would have a series of implementations. There's a human in the loop. Society is changing. You have new sensors. You have new wearables. You've always got to think continual learning. So the RL agent is part of the intervention now. So here's hard steps. I didn't mention V1. V1 was a setting in which the actions were chosen according to a pre-specified behavior, what's called a behavior policy. In certain states, you could choose a variety of actions. In other states, you could only choose one action. That's the way V1 was set up. And then there was learning between V1 and V2, between V2 and V3, and up to V4. And all of these, the population changed, went from sedentary people to people with stage 1 hypertension in V2 and V3. This was at Kaiser in Seattle. V4 was in Southern California with overweight people. Each time you have slight changes. At this moment, there's 5 components that involve sequential decisions, and 2 of the components are using online algorithms. I'm just going to talk, if you've heard me talk about hard steps before, this is the component I usually talk to computer scientists and statisticians. This is a setting where there's 5 decisions per day. There's the action space is only binary. Send one of these contextually tailored activity suggestions. The activity suggestion is tailored to the weather at that time, the time of day, where you are at that time, and so on. And the algorithm gets the reward of a subsequent 30-minute step count because the activity suggestion is intended to help the person be more active at that moment. The primary reason why I brought this is to emphasize this nature of implementation, learning by humans, implementation, learning by humans as you go through. So in this case, it was the RL algorithm and V2 and from V2, V3, and V4 it was identical. Other components of the intervention were enhanced. And so this is the RL algorithm that was run in V2, V3, and V4. We're going into V5, and the RL algorithm will be totally rebuilt. So what it did was it used a Bayesian linear regression for the reward function, that is the mean of the reward given current state and action. That was the learning algorithm. And then the optimization algorithm used posterior sampling. So this looks like it's a Thompson sampling, classical Thompson sampling algorithm, but it's not really because this, so let me just talk to you about posterior sampling so that we're all on the same page, just to make sure we're together. So what happens is the optimization algorithm uses the inference from the Bayesian linear regression to calculate a probability about the posterior distribution. And this was the posterior distribution that the advantage of sending a suggestion in state S minus the advantage of not sending a suggestion is greater than a particular threshold. It calculated that probability, and that probability was used to determine whether to send a suggestion. This threshold, if you're familiar with Markov decision processes, it came from a Markov decision process that was built on V1. So each implementation, they lead from one to the next. They set you up for the next implementation. So I wanted to talk about open problems here. So the current setup it has this little, there's my former slide at the very top of the right. So a lot of the current research is what that human in the loop might be doing, okay? So there's work in if you're going to run an implementation, a clinical trial using an RL algorithm, how can you determine how many users you want? How do you do primary analyses? What are the primary estimands? All of this is relatively primitive, but it's being used by a large number of studies. So a lot of work could be done to improve this. Okay, it's all very primitive, but at least it's there. And then the second bullet point is, at least the beginnings are there. The second bullet point comes on, again, it's about that human that's between the implementation. Classically, the idea here was each implementation would be on almost the same population. So the idea was in each implementation, you take that data and you attempt to learn an optimal policy from that batch data. The implementations depended. Some of the implementations have actions following a known exploration policy, which is the case, say, with V1, HeartSIP's V1. This is often, I've seen this with electronic medical record data. You're attempting to use observational data. You have so it's not really an implementation. You just have a batch of data, and now you're going to the future. And then more recently, data that has been collected using a reinforcement learning algorithm in the prior implementation. So there is work. There's work out there. It's enormous amount has been done by people in business schools because of the ad placement problem. There's still a lot to be done, but there's work in all of these areas, okay? It's not like it's totally new. One thing, though, I think that's going to be very exciting going towards the future is how do you warm start the next implementation, the transfer problem. People have mentioned the transfer problem repeatedly, and here the transfer problem can involve small changes in all of these. None of these changes are expected to drastically change the responsivity of the individuals, but you do have to be concerned about that transfer. One of the issues here is how do you use population level data on a wellness population to warm start the algorithm for a clinical population. This is really an interesting area. As far as I can tell, it's pretty much completely open, this area. There's just not much there. Another area which I think is very interesting, I don't work in this area at all, but I strongly feel that we need more work in this area, is often the team that's involved, the whole health science team that's involved in these multiple implementations, they want to do mechanistic research. You know, they want to understand, they want to explore the causal chain. And how do you think about the structural DAG with the mediation model? How do you do that when your data was collected with an RL algorithm? It's really interesting. Some careful thought has to be given to this. So that's another area that's very open here. The whole issue of trading bias and variance, that's our expertise. You know, we're the guys. I mean, we're the people that do that. This is how we think all the time about trading bias and variance. How do we use working assumptions on the multivariate distribution, like this time-varying directed acyclic graph that evolves over time? How do we use working assumptions on that to speed up learning? HeartSIP's V5, we're going to be trying to do this. Whether we succeed is a different issue, but the whole game is to speed up learning. What does it mean to speed up learning? It means reducing variance and paying the price with a little bias. Essentially, that's what we're talking about. This second bullet point, I think, is I find it very subtle, and I just want to make some statements. So for the longest time, everybody in the current implementation, they said, oh, well, if you're going to do theory, you have to develop an algorithm which does regret minimization. That is, maximize the rewards in that implementation. The minute you realize you're in a continual learning setup, this is completely bogus. Because the implicit assumption when you want to do regret minimization is that you're in a stationary world, you're going to learn the policy and just deploy it from then on. That's not the game. We need to regret doing regret minimization. Theory for continual learning is desperately needed here. How do you think about what you should be optimizing? And it's a tracking problem. We have to think more, what do we mean by, what do you optimize in a tracking problem where you have sequential decisions? I really think we're the field, we've got to make progress. It's really important. So going to this trading bias with various, this is a disaster. I mean, it's a constant pressure on me to trade bias versus variance because we're trying to learn online. You know, these are online algorithms. Okay, so let's go to oralytics. As I said, this is a collaboration with Procter & Gamble, and it involves all these engagement components. So here it was pretty clear that we needed to trade bias versus variance. The study only lasts 70 days. You only have 2 decision points per day. You're not going to be able to learn individually on a person. So what were our first efforts at trading bias versus variance? I think that's on the next slide. So first of all, our prior, we're using a Bayesian method. The prior is informative. In my world, the prior is always informative. Right. I'm totally into informative priors. Yeah, well, pretty informative, yeah. And the action space, it turns out, is much larger than 2-dimensional in the oralytics, okay? I think it's 6-dimensional. But what we end up doing, because the signal is so low compared to the noise when you're experimenting in real life, what we compare is any kind of nudge versus nothing at all. So the algorithm is only going to be forced on, do we bother that person or do we not bother that person? We'll do after study inference with humans will be used to discriminate between the different types of actions. We're using Thompson sampling with an engineered reward. So the reward was engineered in a sim to real life setup. I can speak about that. This is a setting, because you're going into the field, you're going to be running an online algorithm. This is not the simulation environment you build. It's not like a simulation environment you build for JASA or the Annals or something. These simulation environments are built off of real data where you're trying to anticipate all the problems that might occur, and you're trying to find an algorithm that lives on a Pareto boundary of Okay, so one thing we learned in these intensive simulations we did prior to implementing oralytics in the field was we learned that even though the individuals in our existing data from the same sensor suite exhibited incredible heterogeneity, it was better to have an RL algorithm that pretended like they were all the same and pooled their data. Talk about bias versus variance trade-off here, right? So the noise is so high, it's worth incurring the bias due to the fact that the people are quite heterogeneous. You get better sums of rewards, or better, in the sim environment, we got better brushing behavior over the duration of the study by acting as if everyone was similar, even though they're not. Okay, so I want to talk to you, because here's a place where statistics really came and saved us. Okay, I just want to, first of all, thinking about the problem as a statistician was useful, but second of all, statistics had to save us, and I'm going to tell you why. We're already funded to do 2 implementations in this study. And actually, we just got funding to do a 3rd implementation on a slightly different population. But I didn't know that at that time. I just knew we were going to have 2 at this time. Okay, so all of a sudden, here we are in implementation 1. We're going to trade bias and variance and pool, the RL algorithm is going to pool across everyone. This is a disaster for that little human. You see him? Oh, no. It's a disaster. Why is it a disaster? It's a disaster. Statistician comes to the rescue. The theoretical statistician. Okay, so let's just think about this, how the theoretical statistician came to the rescue. Okay, so here you have your patients. I made it simplified. The problem's been simplified for me to explain things. So just think of the patients as rows. This is at time 1. You get the state, the algorithm gets the state of each patient. It randomly chooses the first action, say with probability 1/2. And then it observes, it inputs the rewards. In this case, it's brushing quality, a measure of brushing quality. So the algorithm pools all their data, together, and it produces a posterior sampling probability with these, it's an engineered reward. It takes that, this is just one posterior policy, one posterior sampling policy. And now at time 2, it looks at the state of each of your people. It applies that one policy to each person, inputs their state, and outputs whether or not, what action to choose, whether or not to nudge them or not in this particular setting. It redoes it. It updates the posterior distribution. It again produces one sampling policy. What have we done? We've taken independent participants, we've applied RL, and we've output dependent participants. Dependent in a very peculiar way. They're not dependent in the sense that people knew each other or they had the same physician. No, this is not, it's not that kind of dependence. The dependence is only through the algorithm. So the actions for one person is informed by the responsivity of another person at the prior time point. What are you going to, so now you have dependence. We know from survey, we have classical statistical training. We went through statistics. We know from survey sampling that you have to adjust you have to get a design effect. You have to adjust your standard errors because you've produced this weird dependence. And so, in effect, even though you think you have a certain level of information, you have less information than you think because of the dependence. You don't have independent units. Theory to the rescue. This is great. This is here. We had to until we. It was great. Kelly did a great job, the PhD student who developed the method. But until that method got developed, we could not run that trial. That method had to get developed so we could justify the sample size, so we could register the trial in clinicaltrials.gov. As you all know, that's what you do in our world. So we had to develop a method to adjust the standard errors. And it was totally cool. It used some cool blah, 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 mathy, and change of measures, uniform central limit theorem, whatever. But it was, yeah. And now, MyWaves, we have a study that's going into the field. We're going to use a much more sophisticated approach to pooling data that looks at measures of similarity between participants and pools only to the extent of that similarity. But we're able to do it because of her work. So I have just a few more slides. These are the emerging challenges. So big issues that we're really struggling with. We're going to really struggle with the first 2 bullets in HeartSteps V5. We have a distal health outcome we want to achieve, and the rewards that we can achieve in the meantime, they're expensive to collect. They impose burden on the individuals. How do you develop an algorithm in this setting? I can't tell you how to do it. I just say you need to figure it out. This has to be done. Can we use causal DAGs, mediational models, to improve the learning of the algorithm? Can we do this in a robust way so that we don't have a disaster at the end of the day? This is all, I think these are really big questions. And how does bias versus variance trade-off enter here? Maybe we can incur some causal bias if we get better outcomes. It's not, yeah. Here's this first bullet point is something that's really been bothering me for quite some time. I think going forward in the digital intervention space, almost all of our states are going to be predictions. Predictions of the person's current stress level. Predictions of whether or not they're engaged in the app. Predictions of whether or not they're going to recharge their wearable, and so on. Predictions have a lot of, we've heard this today, the last 2 days, and these are all black box machine learning predictions. We have to have measures of confidence. Why? The measure of, if we don't have a lot of confidence, that may influence what action we even choose. Some actions will only be suitable if the confidence in the prediction is high. Think suicide ideation. This is a perfect one. You need, if the confidence in your prediction of suicide ideation in the next 4 hours is low, that's going to change the kind of action you'll provide. Another one that's, we've just gotten into this area, I strongly believe is very open. This computer scientists, as best I can tell, haven't gone there in either one of these, okay? I mean, it's pretty open for us because we have the right background. How do you conduct post-mortem analyses? So with hard steps, I have all these beautiful graphs, and it makes it look like the algorithm has learned an enormous amount about the individual and is personalizing the nudge. Yeah, right. Do you believe this? The algorithm itself, it's posterior sampling. It's stochastic. We know that you can get beautiful results just due to stochasticity. How do you do post-mortem analyses which look at that the performance of that algorithm and say, oh, what you want to do is you want truth in advertising. And the reason why this came about was I had these great graphs. I thought, okay, we're going to put them in the next grant. Because if I put these graphs that show beautiful personalization in the next grant, I'll definitely get funded because, I mean, I have to get funded. And all of a sudden, are they real? Is this just totally spurious? We really got to think about this carefully. We have some first ideas, extremely primitive ideas. Actually, everything I do is very primitive. I don't do anything sophisticated. I do shallow learning, not deep learning. Okay. These are big teams, tons of software engineers, tons of people, oral surgeons here, human-computer interaction people are on these. There's a lot of computer scientists, statisticians, behavioral scientists. We all have to work together. Thanks.
Any questions?
Many thanks, Susan, for your excellent talk. And I cannot agree more with many of the points that you mentioned during your talk, especially on non-stationarity, on like mediation, on like sparse rewards. So because that's also something that I encounter in my research as well. So I just want to elaborate on the point of weak signal. So I think weak signal is not only like frequently encountered in health studies, but it is also encountered in many other like real applications as well. So for instance, I also work on like ride sharing, and to my knowledge, like in these settings, the signal is also very weak. So I just wonder, like, have you measured like how much improvement that your estimated optimal policy does, like compared to like a standard baseline?
Yeah. So that's a lot of the post-mortem analysis is related to this. Oh, I'm sorry. Thank you. The post-mortem analysis does a lot of that. So for these people, did the algorithm really help? For this subgroup, we're using resampling methods to examine whether or not the algorithm was really worthwhile for a particular person or a particular subset of people. Now, in oralytics, we're going to be under the gun. The second implementation, there will be a 2-arm randomized trial, and we're going to be 1 arm. Now, we haven't figured out what the other arm will be. There's a lot of pressure to make the other arm pretty sophisticated. So we're going to be under a lot of pressure to see if the RL can really pay off in a marginal sense, because that's what a 2-arm does, right? It's marginal. The post-mortem analysis is more looking at resampling early indications that there may be a subgroup or different types of people that might benefit more versus less. The low signal is exactly the reason why we our community is needed in this area. If the signal were high, you don't need it. You can be back into robotics. You can do games. It's not our game anymore. But the fact that it's a low signal means this is our game. It's the bias versus variance game. It's how can you bring in domain knowledge in a way which it doesn't ruin things. You'll get a little bias, but you'll increase the learning speed and you get better performance. So the very fact it's a low signal means it's our game. Yeah.
Yeah, thanks for the nice talk. So my question related to the previous question, but more on your Bayesian linear regression model for your reward function that you mentioned you use informative prior. So I'm just wondering, how did you specify informative prior using domain knowledge?
Notice that we have a sequence of implementations. So, so each implementation is used to rebuild the prior. The first implementation, so in all of our studies, the first implementation, the pre-existing data we have is impoverished in some way. It depends on the setting. Like in Heart Steps, the pre-existing data had the same sensor suite, and it was a pure exploration policy. It was great. Same actions, it was fantastic, but a slightly different population. And so we built the prior based on the prior implementation. In Oralytics, we were fortunate enough to have data from the same population with the same sensor suite, but no actions. So that sim to real life, it's used to build the prior as well. So we both use, so there's usually, in Oralytics, I think we had 10 variants of the simulation environment, and we would build the prior based on one variant and then test it in the other environments. You know, so it's like almost like a CV kind of game. Yeah.
Thanks. Also, yeah, have you tried like using like a?
For the interest of time,
sorry.
We have to cut here because we do need to go to lunch. This session is suspended because we will have 3 more lightning talks.